Thank you very much, Rashmi. It's incredible what the SJIA Foundation has achieved. And sometimes from across the pond in UK, we look and marvel at what Rashmi and colleagues have done. And the presence of the virtual conference this year has enabled us from the rest of the world to join in as well. And in our conversations with Rashmi over the last couple of years, we've always talked about the fact that this disease does not know geographical boundaries, and that there is a significant proportion of children and parents of these children and families with systemic JIA, or for that matter, adult onset Still's disease, who are unfortunately suffering from the same problems, and sometimes accentuated by certain geographical and socioeconomic variables. So when we discussed this, what we wanted was perspectives from as broad an audience as possible. So what we're going to hear today is from four of my colleagues who are managing systemic JIA in different parts of the world, and we've deliberately chosen these to reflect as much as possible different continents. So first we'll hear from my good friend Christian Scott, who's based in South Africa. And we've asked really all of them to address three key areas. What is the burden of this disease in their geographical setting? And second is, how do they manage, and what are the drugs which are accessible to them, and what are the drugs which are inaccessible to them? You already heard about the difficulties in accessing anakinra in US through insurance systems. Unfortunately, anakinra is not even available in half of the world, even if someone's willing to pay for it. And then we'll hear from my other good friend, Satish Kumar, who works at Christian Medical College, Vellore. And really my interest in the global perspective comes from the fact that I trained in India, moved across to UK, did my fellowship in Canada, and I'm now been working in Bristol for the last 2 decades. So we'll hear from the perspective in India from Satish Kumar. And we'll also hear from my colleague and friend, Yelena, who is working in Belgrade, to give us both a Serbian and a European flavor. And from South America, we have Cecilia, who will give us the input on the management of systemic JIA in Chile, and really a South American flavor as well. So without much ado, I have great pleasure in introducing my friend and colleague, Christian Scott, who will give the African and the South African perspective of systemic JIA. Christian, over to you.
Thank you very much, Ram, and thanks for the invitation. It's really wonderful to be able to connect with all of you. I love nothing more than to speak to small, passionate groups of people about things that I'm very passionate about. And this is one of those, because there is a huge unmet need and a huge burden of suffering on children in our parts of the world who develop this condition, as there is in all parts of the world. So I'm a pediatrician in Cape Town, and these are some of the perspectives. I've just taken three issues to highlight. Try and advance my slide. The first is awareness and diagnosis. Now, I bet all of the families with kids with SJIA, or most of them, unless they were lucky to present in Cincinnati or somewhere, had some difficulty getting a diagnosis and finding the right diagnosis. And many people will know the discomfort that they felt during that process, and the suffering that their children experienced, and the worry that they themselves had. But I put it to you that here in Africa and South Africa, the situation is probably much worse than in many other parts of the world. Children present very late, having been missed, often already being treated as congenital HLH by oncologists, often having been treated for TB several times, up to a year of TB treatment with no response, and so on. And the level of diagnosis, or the rate of diagnosis, the degree of delay, depends to a large extent on the local pediatric rheumatology or pediatric footprint and the expertise that's available. And I'll show you some of the challenges around that. And in our situation as well, the delay in younger children is just longer. I'm sure that's a global phenomenon, just because there are so many causes of fever in young children, and infection is such a predominant cause for fever in our setting that people are very reluctant or are not empowered to move on from that perspective. So just to remind you, I always take the chance to speak on behalf of all my colleagues in Africa, and Ram and others have seen the slide a number of times, but it bears remembering that Africa is an incredibly large place with more than 1 billion people, and more than 60% of them being children. So you can imagine the burden of disease. That map just shows that the landmass of the USA, China, India, and Eastern Europe, and most of Western Europe can all fit into the landmass of Africa. And despite that, we have very few pediatric rheumatologists. The stars you see there are centers with pediatric rheumatologists in Africa. But for instance, it looks all very comforting because the stars are relatively big. But take the star over there in Nigeria, for instance. That rheumatologist has returned home yesterday, having trained here, and she has responsibility for 250 million people. So you can imagine the challenge of getting diagnosed with systemic JIA in a place like Nigeria, or a place like one of the countries that don't have a star. What is the burden really? Well, of course, it's unknown, because the burden, as you all know, depends on whether people are diagnosing it or not. But what we do know is that the relative proportion of children with JIA appears to be higher in most of the reported studies from Africa than relative to those reported in the United States and Canada and so on. So if you look at the second to last column, SJIA in most of the cohorts, and we've got here Zambia, Kenya, and Nigeria. Bear in mind, that is all the reports from Africa at this stage, apart from one further report that I'll show you in a minute. But most of them show SJIA proportions that are nearly double what's seen in the rest of the world. Now, this is probably some kind of referral bias with only the sicker children getting to hospital, but it bears teasing apart, and it certainly shows that there's a level of this disease that must be undiagnosed in countries where there are no pediatric rheumatologists. This study I learned about yesterday was from a colleague of ours in in Saudi Arabia. We were speaking at the Egyptian conference yesterday, and he showed us the results that in a compilation of Arabic countries that have pulled their data, systemic JIA makes up 24.5% of the patients. So a quarter of patients in their cohorts suffer from systemic JIA. And as you know, that's vastly different to the more better characterized cohorts in the world in the West. Our second problem is comorbidities. Tuberculosis is so prevalent in our setting that it bedevils not only the diagnosis of this condition, but also the management thereof. Bearing in mind the burden of other infectious diseases being incredibly high, things like chikungunya, virus infections, rickettsia, scarlet fever, Epstein-Barr virus infection, etc., can really make the diagnostic delay to diagnosing systemic JIA very long, because people spend a long time trying to exclude all of these things. And many times orthopedic surgeons are involved doing biopsies on swollen joints, waiting 6 weeks for cultures, or treating for 6 months to see if it'll go away. And I'm sure my colleagues in the rest of the less resourced areas will bear this out. So that's a real problem in our setting. And then once we start treating children, of course, high doses of steroids, cyclosporine, tocilizumab, etc., there's a huge concern about infections. What about treatment? Tocilizumab is registered in many countries in Africa and is available, but usually only 2 patients who can pay. And so it's a tragedy to watch patients pay for a few months, get remission, and then having sold everything they own to be able to afford those 3 months, no longer being able to afford any medication at all for their child. And of course, you can imagine the outcomes. So in South Africa, I'm lucky in that in the state sector, I can prescribe tocilizumab in my hospital or in my province, but other provinces haven't been able to convince their management to allow that. And so even in South Africa, there's a real limitation to accessing drugs like tocilizumab. We don't have any access to IL-1 inhibitors at all. Canakinumab, to put 2 patients on canakinumab in Cape Town would exhaust our hospital's pharmacy budget for the entire year. So it's just not feasible. We have used anakinra, and what we do is we import 100 milligram syringes and divide them into 0.1 and 0.2 mil aliquots, and so stretch them over an extended period to try and make the treatment at least within the range of affordable for our patients. We use cyclosporine a lot for MAS. Unfortunately, we have relatively good results. But of course, we run into great trouble when children don't respond to cyclosporine or have had a bad reaction to tocilizumab. I want to make you aware, it's not all doom and gloom. We, as part of the Global Task Force for Musculoskeletal Health, we are currently submitting an application to the WHO to have both tocilizumab and anakinra included on the EML. Ram and his team have helped us to work on the tocilizumab application. And we hope that this will enable other countries to have better access to these drugs in the future. But at the moment, it's, I would say it's as good as inaccessible to anyone in Africa. The cold chain is another issue in Africa. As you know, the new coronavirus vaccine that needs to be kept at -70 degrees is not going to make it to our shores very quickly because we have difficulty with much more modest cold chains. So those are just some of the problems. I don't want to sound pessimistic. The number of rheumatologists in this continent is increasing, and we're busy with many educational activities, and I'm sure it'll get better over the next few years. And I leave you this picture of 3 little girls in our clinic, 2 of whom had to travel over 1,000 kilometers a month to come and get their supply of tocilizumab at our hospital. But look at the results and look how happy they are. So thanks very much. I hand over to my other colleagues.
Thank you, Chris. That's a fascinating overview. And I think what we're going to hear frequently are the themes you touched on about the training issues or the difficulty in accessing trained pediatric rheumatologists, difficulty in accessing certain drugs, which again, we'll hear from the other centers. And also most importantly, the incredible burden that systemic JIA has in those settings. With that, I pass you on to my very good friend and colleague who comes from the village where I come from, very close to, working in Christian Medical College, Vellore. Satish has done an incredible job after training in Canada to go back and set a center which serves a large proportion of South India. So Satish, over to you.
So my screen is on full screen?
Yes.
Show?
Yes.
Thank you. Good evening here. Good morning to all of you. Thanks, Ram and Reshmi, for inviting me to give our Indian perspective of children with systemic JIA. So, as Chris Scott showed Africa, I'm just showing India, where I am from. You can see from South India, there is a province called Tamil Nadu. In Tamil Nadu, we have a small place called Vellore. This is my hospital. How systemic JIA is different compared to West. So, I was trained in sick kids and I came back to India in 2009. Until now, we started our pediatric rheumatology clinic in our hospital. So far we have 800 children. You can see here, most of them, 35% of our patients belong to have systemic JIA. If you look into the Western data, you will have more of oligoarticular JIA. So in India, we have a lot of systemic JIA followed by enthesitis related arthritis. This is what the cohort we see in our place. Okay, so what are the challenges? As Chris Scott said, we have the same challenges what he has there in our country too. So the 2 main challenges which I feel for management of systemic JIA is the availability of the drugs, and second thing is the affordability of the drugs. When it comes to the availability of drugs in India, so we have almost all the biologics, etanercept, infliximab, tocilizumab, secukinumab, and rituximab. We have the original molecule, innovator molecule, and we have the biosimilars also. And if you notably notes here regarding to systemic JIA, what we are lacking is your iron-1 blockers. We don't have any anakinra, canakinumab, or etanercept in India. So that's one big challenge we have. Second challenge is the affordability. So when you look into the drug cost, I just translated the euros, how much it comes to. So when it comes to, you can see the tocilizumab 80 milligram vial is only 71 euros. Okay, but India, the problem is, even though when I compare to the euros, it looks like very cheap, but compared to what happens in India is, most of the patients, we don't have a national insurance. So most of the patients, almost I will say 80 to 90% of the patients has to pay out of pocket expense. And the insurance coverage is usually from the private, is usually less than 10%. And government has got insurance mainly for their employees, especially somebody is in the army, and they have their insurance coverage. And another thing is for the very low socioeconomic status according to the government guidelines. And most of the time, the government insurance covers only the life-saving drugs and the procedures, not our, according to them, rheumatology comes under the chronic diseases. They feel that that is not important. And you know that per capita income as of January 2020, this is before COVID, it is only 11,254, which is about 130 euros a month. So you can see that how many people can really affordable the biologics. Okay, so what we do, so we cannot leave these children. So how are we treating our children? So we have other drugs, the cheap drugs compared to biologics is cyclosporine. This is one of the cheapest alternative to biologics. This is one of our friend from Calcutta who has published recently in a journal, in Indian Journal of Pediatrics, where 15 children were included. And out of the 15 children, 13 children responded. These are the children who actually have disease flare on tapering steroids. So what did they found? They found out, you can see the fever differences are very good in almost 13 children, and the joints also improved with cyclosporine. ESR CRP was reduced in 13%. The main important thing I want to tell is the decrement of the dose of steroids to 50%. So it is, you can see there's almost 13 children out of 15. This is what their experience which they published. So we use, so what they finally concluded, compared cyclosporine was effective in almost 75% of the patients who has relapsing steroid dependent SJIA. And if you look into the cost of therapy, actually cyclosporine was much cheaper. It is about 132 euros per patient over a 6 months period, which is almost equal to 10 times less compared to when you give tocilizumab for same duration. So second drug we use to treat children with systemic JA who cannot afford biologics is a drug called thalidomide. So thalidomide, it is not new. There are a lot of, it is an old drug. We have a lot of case reports from the various parts of the world. This is from the Thomas Lemon in 2002 itself. He reported children respond all case series. There is no big data on that. And so this is also from Mumbai. We have again few children work very well. This is again from Mexico, 3 children. So there are a lot of case reports and case series for thalidomide. We also use thalidomide in our children who cannot afford biologic, especially tocilizumab. So what is the biological protocol followed? So when you look into all the ACR European recommendations, every 2 weeks you give, nobody knows how long to give. We don't have a certain protocol to stop biologics. So what we do is based on the economical status of the child, of the parents, whether they are self or insurance coverage, patient and the doctor preference, and recommendations as per the evidence we try to use. And we select very selected patients who can able to afford biologics at least for minimum of 6 months. We don't give it one dose and we don't divide and all those things. We'll give it for 6 months and we'll try to taper. I know there is no big rockets. We don't have big science behind that. How do you taper? We make it every 3 weeks, every 4 weeks, and try to taper and see the response. And whenever the disease comes, we use it intermittently during the flares to put out that disease. So it's really managing children with systemic JA is really a challenge in our country. And but we are managing our children, and our children are doing well, except few of the children had the eventful things. Otherwise, we are able to manage our children well. Thank you. Thank you once again, Ram and Reshmi.
Thank you very much, Satish. Again, I think we're going to hear this recurring theme, but without much ado, I'll now pass on to Elena, who is also the treasurer of the Pediatric Rheumatology European Society, a senior pediatric rheumatologist who is based in Belgrade, to hear a European perspective. Elena, over to you. So while Elena is loading her slides, we were hearing in the chat about people talking as to why there is more SJIA in India, and something we can come to if there is time, but we think it might be a true association as well as a referral bias. It's going to be very hard to untangle this. But Elena, are you able to screen share now. Excellent. Elena, over to you.
Thank you for the invitation. This is a very interesting conference for me, and everything that should be. It's said, yes, I'm coming from Europe, but it comes that it looks like that even in Europe, which is considered as being you know, successful in treatment and with a lot of resources and possibilities, things does not work so well in some regions. Please, next slide. Can you do the next one?
It's not advancing.
Just stay in this mode and just to click on the slides, Tara, rather than.
Oh my
Okay.
gosh.
However, the region I'm coming from is southeast part of Europe. So it's a very heterogeneous region.
Right? Look.
So go for the second, thank you. It's very heterogeneous region. First of all,
Right?
it's covering numerous countries. Romania, Greece, Serbia, Bulgaria, Croatia, Bosnia, and so on. The issue is that it is around 60 million inhabitants living there. It is not, there is no evidence of any that you could say what the burden is, because we do not have a registry or anything like that in this region. But I tried to calculate the number of children living there. Then, according to the usual incidence, which is the same all over the Europe, the number of JA patients, which is almost 15,000, and the number of systemic JA patients is 1,500. Please, next, click, just click. So there is a huge diversity of religion, ethnicity, economy, health service organization, and funding. And that is very interesting for, you could say, relatively small region. And this influence, unfortunately, the quality of care that we can provide in this small region, and a lot of differences on maybe only 100 kilometers being away. Please, the next slide. What are the problems we are facing in the current management? Of course, we are following the recommendations for treatment and so on, but yet there is late primary care providers referral to the tertiary. Usually we need a tertiary level hospital for the diagnosis, which foster quite a delays in timely diagnosis yet. Then the problem of complete lack of national registry for any pediatric rheumatic diseases, and subsequent epidemiological data, especially for systemic JEA. This is something that I would propose maybe to this meeting to be used as a global initiative for this type of patient. Then, of course, there is a lack of funding. Yes, it is a Europe, but it's not the wealthy part of Europe. So there is a lack of funding there. And there is a lack of organized research initiative, because I deeply believe we notice there are differences in different regions as just presented. So yes, we need a lot of research to find out why we have differences. Probably due some different genetics on the background and a lot of issues, but we need lack of research. Then, unfortunately, on the contrary to the United States, there is a lack of inactivity of parent and patient organization who could fight for their rights on organized matter, organized way, and maybe could succeed with 12 governments to commence the same approach to this disease, which is not always easy. Then, unfortunately, still, I think that in many parts of globally, and in this part of Europe, eastern part, there is an inappropriate and outdated perception of a potential outcome of this disease, systemic JA, but the other subtypes of JA. And then, yes, we must say that there is a restriction on availability of medication, especially some types of biologics. In this part of Europe, we have in most of the cases tocilizumab available, but only IV possibility, not the subcut yet. We are expecting it. But when it comes to IL-1 blockers, only a couple of countries can afford IL-1 blockers on the insurance. And yes, this is a wonderful initiative that these medications should become essential, at least for children globally. So I think that we did not mention, but for making diagnosis of systemic JEA, you have to exclude the numerous number of potential diseases. And to do that and make a proper diagnosis, you need very expensive and good genetic facility. You need very expensive and good serology and microbiology facility, and in many times good imaging facilities, which is unfortunately not available in many countries, even in Europe, like in probably India and South Africa. And that's maybe the reason why sometimes there is a difference in the number of SJIA diagnoses, because some of them are maybe some other autoinflammatory disease that could not be diagnosed. So please, the last slide, please. So what are the, can you change the slide, please? So what are the
30
unmet?
seconds more. We need to just leave some time for questions. So.
Okay, then thank you. Should I finish?
Ram?
Ram is gone.
No, I'm here. I'm very much here. Thank you very much, Elena. So I think you've given a valuable perspective, and we'll bring the other bits in the discussions. So in the interest of getting questions from everybody, we'll now move to the South American perspective from Cecilia Polly. Over to you, Cecilia. And then after a couple of minutes, we can bring everybody for questions.
I first want to thank you very much to Rashmi and the Foundation for this very nice invitation, and I'm really honored to be here. So this is Santiago. For you, those of you who haven't been here, we're very close to the mountains, and this year, because we were all locked down, we didn't have so much pollution, and we could see the mountains with snow very close to the city. So Chile is the long country along the west coast of South America. As you can see, it's much smaller than Argentina or Brazil. Total population in Chile is 19 million people, and about 7 million live in Santiago, which is the capital city where I'm based on. We're an admixed population. We have a very small native community and have a European ancestry, mainly from Spain, but also from Germany and Italy, depending on where in the country. Our health insurance system, and this is very important when we speak about GIA and SJIA, is 70% public. So we have these public funds which are associated to public hospitals, which serves 70% of the population, and then the ISAPRE system, which is a private system, and private clinics, which serves 22% of the population, and a small amount of the population is uninsured. Hospitals have a centralized referral system, meaning that if you have a complex disease along farther regions in the country, you get referred to Santiago, to one of the pediatric hospitals. There's very few rheumatologists in the country, so 25 pediatric rheumatologists and 8 immunologists that also have some training in rheumatology and see some patients in the different regions. But most of us are based in Santiago. We do have monthly meetings with people both in Santiago and in the regions, and this is very useful to create guidelines and discuss patients. So as my colleagues have exposed here, we also don't have a clear view about the burden of disease in Chile. It's estimated in 10 to 100,000 children, and 15% of those are supposed to be systemic GIA. So the estimated, according to the pediatric population, would be 70 patients, which, you know, is not far away. I conducted a very small survey among the few pediatric rheumatologists in Chile, and we're supposed to have around 68 active patients. So it's not too far from what's been estimated. The access to clinical diagnosis is a bit hindered by the low number of specialists. And because we're all concentrated in Santiago, there's a low coverage. So you're more unlikely to be diagnosed if you're not in Santiago. Again, these monthly meetings with people from other regions help. But once the diagnosis is suspected, we're very lucky because we have this that we call the GES program, which is meant for 81 different diseases, and one of those diseases is SJIA. Another rheumatologic disease that is covered by this program is SLE. And this covers from the diagnosis to the clinical assessment to treatment. We don't have all drugs covered in this system. I'm going to talk about this a little bit later, but at least it covers the basics for this disease. As long as for biomarker availability, we don't have a lot, just the basic labs, the antibody testing, we have ferritin, but we don't have any clinical way of assessing cytokines except for IL-6 levels, which we now have thanks to COVID. Interferon signature, which may be useful for some patients, it's only available on a research basis. So the biologics that are covered under this SJIA GES program are tocilizumab, and that's the only thing we have for systemic GIA. Anti-TNFs, infliximab, etanercept, and adalimumab are covered. Abatacept is also covered. And then we have these other biologics which are covered by some law, but they're not in the GIA GES program, so we can't get them for covered for children. Canakinumab is covered only in the private system by special request. It's not in the GES program. We've tried to get it in there for systemic GIA patients, but it's not yet covered. However, it is approved for the use in Chile, which we have problems with anakinra. Tofacitinib is only approved in the adult RA GES program, so some patients that we think may need tofacitinib, we pass them early to the adult system so they can get this medication covered. And then ruxolitinib or baricitinib, as other JAK inhibitors, are only available, the patients have to pay for it. It's not available through the program. And then we can get rituximab through the GES program for SLE. Anakinra, as I said, is not registered in Chile, so if we need anakinra for a patient, they have to pay for them. It's for it themselves, and it's very costly. Emapalumab, as in most parts of the world, it's not available. So the current treatment for SJIA is NSAIDs, pulse steroids. We use methotrexate if there's persistent arthritis. We are very lucky to have tocilizumab in the program. We can use canakinumab, but as I said, it's not covered. As many of my colleagues have presented, we also use cyclosporine for resistant cases, and we can use anti-TNFs for those patients that evolve with chronic arthritis. If patients have MAS and it's refractive to treatment, we do use cyclosporine, etoposide, and also cyclophosphamide may be considered in some cases. Again, if patients can pay for the medication, they can get canakinumab or anakinra. So as far as what we need to do in Chile and South America is register and report. If we don't know your epidemiology, it's very hard to get drugs covered and to get the system to be involved with these diseases. So we would need to include other biologics in this GES program that we have. Unfortunately, this is not the case for other countries in South America which don't have such program. We would need to have availability and coverage for more biomarkers. Perhaps IL-10 may be useful for some patients. Create awareness and advocacy in the Latin American region, and not as individual countries. I think this would help to have more drug availability, especially IL-1 blockers, which for the most part in South America we don't have. Increase local research and access to drug trials. A lot of the drug trials are not available to enroll patients in Latin America, and that's a problem. Also in Chile, we have some regulatory barriers that we're trying to overcome to make this available for patients. And improve awareness and dedication to systemic GIA among the patients group. We do have a patient group for arthritis, but they're not really working on systemic arthritis, which may have different needs other kids with arthritis. And with that, I would really like to thank this invitation, and thanks to all my colleagues from these different institutions which provided some information for this talk. Thank you.
Thank you, Cecilia. Rashmi, I think we've heard perspectives which are, so I wonder if you want to comment on any questions that any of us can answer or bring in, or if anyone has any issues.
Sure, I can start off. So it's really, I think, as you can see from the comments that patients are making, for many of us in the US, it's really heartbreaking to think that the biologics are not available, which have been so central to many of us. And I was curious, like, are you starting, now that the JAK inhibitors are getting available, are you starting with those as frontline, like starting with that in any of your centers?
So we have not tried tofacitinib, JAK inhibitor, which is available in India. Now the patency, even though it is costlier, now the patency is gone from Pfizer. Already 6 companies have marketed tofacitinib in India last week. It is very, very cheap, the drug. If we have a very good evidence, most of the time we are not going to wait for IL-1 to come to India. We will shift to small molecules like JAK inhibitors.
I think that's a very important point that Satish makes, Rashmi, because the small molecules are a bit like paracetamol or ibuprofen. When the patent goes, they won't be as expensive as the biosimilars are, which are still beyond the affordability of most people, even though they are cheaper than the innovative biologic.
Ram can convert that into, I'll tell you the price, 60 tablets, which comes, it is 2,000 rupees. You can just convert and see how much is in euros.
Yeah, it would be about $20 roughly, yeah. So,
yeah, that's all. 60 tablets.
Yeah, I see many researchers on the Zoom. Does anybody else want to, just speak up and give a question for this very interesting set of speakers from around the world?
I think they've all been stunned into silence, and
I'll ask. What about MAS? How do you treat MAS?
Just before someone answers, again, there is a higher incidence of MAS, and we like to hear from all 4 of them, at least from, I know in India and South Africa, there's more MAS than there is reported in the rest of the world. Satish, and then Chris, and then Cecilia.
Yeah. So MAS, because we know that infection is one of the one which precipitate the MAS in children with systemic JA. As you know, in our country, the infection is a #1 risk factor for all of our children who are already immunocompromised. We see a lot of children with MAS, and we have even had a couple of children we lost because we don't have the IL-1, because we tried all the drugs. Especially we start with steroids, we give IVIG, then we give cyclosporine and etoposide. This is our usual way of treating all our MAS patients.
Chris?
It's similar in South Africa. We don't have the IL-1 inhibitors, so we rely very heavily on methylprednisolone and cyclosporine, and very, very rarely have we not gotten away with that, because we can sometimes just control the MAS. We can manage the SJIA with tocilizumab and get away with that. But in cases, in the odd case, we've had to also refer to oncology for etoposide, and that usually, and even bone marrow transplantation is available here. But
have you done that on any of the patients?
No, we've never had. We seem to get away with cyclosporine with our cocktail that we have, but so far so good for the last 10 years.
Interesting. I think I see some. Somebody messaged me directly. I don't hear about the use of methotrexate. Is that not being used?
I can just quickly respond. I mean, it certainly is being used, but but as we know, it doesn't really help too much. So, but everybody does go into methotrexate as well.
Got it.
Methotrexate works for arthritis. Children who has got severe arthritis, they may get better, but not for the systemic symptoms. All our children are on methotrexate. We give methotrexate for even if they don't have arthritis, we use methotrexate.
It's true for us as well. Because we have this specific program, we need to give methotrexate before we can have biologics available. So we may stop it later if we think it's not doing anything, but we use it.
And what about thalidomide? I hear that mentioned. And what stage does that come? Do you like progress up if the first line is not working, then you go up to thalidomide?
So children who are already given steroids, then we give methotrexate and plus or minus cyclosporine. Then thalidomide is like our IL-1. So we keep it as a third line. We don't start as a first line or second line. Thalidomide we use a lot. Even though the literature says thalidomide is a very dangerous drug, we don't see much side effects with thalidomide. We have another drug called lenalidomide, which is little more superized version of thalidomide, which is freely available in India and it is cheap. Some of our children on thalidomide, some of them on lenalidomide also.
Okay.
I can just talk about thalidomide in South Africa. It costs more to use thalidomide than to use tocilizumab. And one thing I want to ask this very important group of people is how can we get the price of these drugs lower for everybody? So we're going to the WHO to try and get them on the list, but we'll only be able to use them if they become vaguely affordable for 80% of the world. So, how do we work together to reduce the price? It always feels to me like we're arguing about the wrong thing. We shouldn't be talking about what we can't afford. We should be asking why is it so expensive?
I agree with that comment.
It's a great question. There are a few more questions. I think people are warming up, but I think it's time to move on to our next panel. Thank you both. Thank you all of you for this great panel. I wish we had more time to ask more questions because it seems like people are coming in now.
But Rashmi, the foundation will hopefully work towards trying to enable equitable access to some of these issues, because what you've achieved in US is incredible. And I think you're a great voice for hopefully improving equitable access across the underserved populations of the world.
I would recommend that everybody ask their patients to join our mailing list, because I think what we do really is just be the voice of the patient. And really, we don't do anything more than that. So, but if you send we've kind of started organizing the US patient, but if you ask your patients to join us, and then slowly we can start engaging. So I would definitely recommend that.